Yeah, good afternoon, everyone. I'm Rhiannon. I'm part of the evaluation team at the North West Ambulance Service. And the past year and a half, I've been evaluating pre-hospital troponin testing. So today I'm going to talk you through a bit about how we evaluated this intervention and what the findings have been. So we've evaluated pre-hospital troponin testing through three lenses. First of all, feasibility. How does troponin testing work in a pre-hospital environment? What are the logistic considerations, the barriers, and is it a good fit for what is a setting that's very different in many ways from the emergency department? Secondly, we've looked at possible benefits. Could pre-hospital troponin testing affect pathways and realise benefits based on those changes? And we're thinking of those benefits in terms of benefits for patients, benefits for receiving hospitals, and benefits for the ambulance service. So sort of the whole healthcare system. And finally, what does the future of pre-hospital troponin testing look like? If we were working towards a large-scale rollout across the ambulance sector, what would the next steps need to be for that to be sustainable and for it to be successful? So this has been a mixed methods evaluation. We've been working with some really complex and interesting operational data. This is data that's captured on the scene in an emergency services setting. And we sort of had to look at it in interesting ways. So there's been quantitative element, where we've looked at ambulance, hospital, and analyzer data combined. And we've set up some data sharing agreements so that we've been able to see the full patient pathway. But we've also looked at qualitative data. So I'll tell you a bit about some interviews with patient representatives and also with paramedics. That's been essential to understanding what the quantitative data meant. Those perspectives help us situate it in the operational context. Because we've been working with operational data, we have had some missing or incomplete data, and that's why we've used all those different data sources. So we've been able to triangulate data sources or sample representative data so that we are able to get a more complete and holistic picture of what's been happening. So I'll start off with some of the quantitative findings. As Phil mentioned, pre-hospital troponin testing was rolled out across 3 stations. 74 paramedics were trained, and those paramedics carried out 638 tests over a year and a half. We've been tracking some metrics to help us understand the operational impact. So time is really important in the pre-hospital setting. And what we saw from that was improvement as the pilot went along in terms of operational impact. So at the start of the pilot, 75% of the tests were resulting in a valid result. And by the end, that had risen to 86%. Similarly, in terms of time on scene, which means the time from when the ambulance arrives to when it leaves the scene, that reduced across the pilot. So this is compared to sort of business as usual chest pain calls. At the start of the pilot, it was adding on an extra 12 minutes, and by the end, that had come down to 9 minutes. When you bear in mind that the test itself takes 8 minutes to run, plus the additional time to get a sample, add it to the analyzer, and interpret it at the end. So the difference, that would take 8 minutes, and the difference was 9 minutes at the end. Of those 638 patients we tested, this is a visualization of the different pathways that they followed. This is a diverse set of pathways, lots of different outcomes, and I think it's useful to understand the operational complexity that we were working in. So what this is showing is what station the paramedic was coming from, whether the test was valid or invalid, and what the patient outcome was. So there's two main groupings of outcomes: see and convey, which means that the patient was conveyed by ambulance to the hospital, and see and treat, which means the patient was either discharged at the scene or advised to go to the ED through a different method, so maybe a taxi. There are some see and treats in our sample, as you can see. In these cases, either that patient was sent via a different transport method, in some cases refused treatment, or there were some referrals and self-care pathways. As Phil mentioned, we didn't change pathways for this pilot. So in those cases, this is showing that there were some patients in our sample who maybe presented with chest pain in their initial complaint, but actually there was something else going on that our paramedics identified, and were able to do a see and treat based on that. The questions that this set of pathways poses are: is this cohort any different from business as usual at this moment? So we'll look into that. And of these see and conveys, who make up most of our patients, could any of those have had a different outcome if pathways had been different? So while pathways weren't changed significantly, we did have some instances of very high or very low results forming part of decisions around outcomes, resulting in a small change in treatment plans. So in some cases, a high or high moderate Tmax was cited in the feedback we got from paramedics as contributing to sort of a higher acuity outcome. So this would be a decision to employ a pre-alert, which means the hospital would be informed ahead of arrival that high acuity patient was coming in, or a blue lights response. We also saw some differences in the very low risk group. So in cases of a low or very low Tmax, the result was sometimes used in combination with other clinical evidence to admit the patient to SDEC instead of the ED. So that's same-day emergency care, and that means that that patient could be seen quicker. They're seen as lower risk and less likely to be admitted. So we can also look at these outcomes in combination with the Tmax results. You can see here that the majority of our patients were very low or low risk group. We only had 3% of the high risk. Compared to business as usual, in the troponin-tested patients, we did see a slightly higher see and treat rate. So 29% discharge at scene compared to 25% of our business as usual chest pain patients. That could be for a few different reasons. It could be a selection effect where lower acuity patients were more likely to be tested. It could be a selection effect where more experienced or more confident paramedics were more likely to be taking part in the pilot. But it could also show sort of a higher confidence based on the Tmax result. If that was then applied to changing pathways, it could be a very useful tool for the clinicians. Of particular interest of these groups are these ones highlighted in red. So these are the groups that would potentially be affected by a pathway change. That's our conveyed very low and low risk patients and all of the high risk patients. So of the conveyed very low risk patients, these are the patients that would potentially be seen, would move to a see and treat outcome where they could be discharged at scene with a referral to a GP or community care. Those low risk patients who are currently getting conveyed to the ED could instead have a pathway where they're being conveyed to SDEC, same-day emergency care. And the high-risk patients could be being taken straight to treatment. At the moment, some of those high-risk patients might be being taken to a local hospital, staying there for potentially several days, and then having an onward transfer to a heart treatment centre. So we could be cutting out that middle journey for those patients. When we apply those groups to the number of chest pain patients that MWAS currently convey every year, we can see that that amounts to 33% of the troponin-tested patients. And projecting that onto MWAS figures shows us that up to 17,000 patients could have a different pathway that would potentially suit them better and get them to where they need to be faster. And of those, around 7,000 could potentially avoid an unnecessary conveyance. So that's per year. And these would be the cohorts that would be of particular interest to the next stages of research for troponin testing. We also looked at some hospital data for the troponin-tested patients who are conveyed to hospital. So we set up data sharing agreements with MFT hospitals and also Tameside General Hospital. And we've been working with the data teams there to understand a bit about what happened in the patient's onward journey after they were conveyed to the hospital. So for MFT, we had a sample of 204 patients. For Tameside, it was 72 patients. What we can see from these is that the diagnoses were quite varied. We had a high prevalence of acute ischemic heart disease in the moderate and low groups. And, sorry, that's just the moderate and high groups. And interestingly, a very high prevalence of respiratory conditions, especially COPD, in the very low groups. Patients were admitted from all the different GMAT categories, but the very low group had extremely low admittance rates at both of the hospital groups we looked at. What that suggests is potentially that those patients would have been safe to stay at home and have a GP referral. Tameside is an interesting one in that those patients would need an onward transfer for PCI or cardiac treatment. And we did see that several of the patients did have an onward transfer. Those patients were all in the high or moderate group, and they stayed at Tameside between 1 and 5 days before being transferred for PCI. This is sort of quite an early look at the hospital data, but it gives us an indication of the types of variation we're looking at and the types of outcomes. So it's sort of an area for future research as well. So I'll talk a bit about the challenges that we identified through the evaluation. Phil has mentioned some of the technical challenges. We did encounter some invalid results, and the main reasons for invalid results tended to be internal analyzer invalid results. It's unclear exactly what causes those, but it can be to do with the sample not being sufficient, or things to do with the analyzer moving. And we also had a significant group of invalid results that were caused by an insufficient sample. When we've talked to paramedics about kind of the features of the analyzers, the main things that they've flagged as important and potential challenges have been those sampling difficulties, so getting a sufficient blood sample for the test to run, the time it takes for the test to run, because time is very much at a premium in that pre-hospital setting, the temperature restraints on the equipment. So we had a heat wave during our pilot, and that caused some overheating where we weren't able to get a valid result because of that. That was the case with the analyzer we used. But there's sort of also the other end of that, where some equipment won't work in cold weather. So that's one of the things to think about going forward. We also needed to keep the analyzer still and horizontal, which is tricky sometimes in an on-scene setting. And it did mean that most of the time we weren't able to do this in a moving vehicle. And finally, the rate of invalid results sometimes meant paramedics weren't able to realise the benefits, or at times had to repeat the test, which also added to that on-scene time. Phil's mentioned the quality control process as the challenge as well. So the quality control process for this device had a high frequency and high cartridge consumption, which poses a significant financial and staff time burden. The QC materials also require refrigeration prior to use. This works in a hospital lab setting, which is set up for that. But the material requires dry ice, which can be dangerous if used in a small space. And carrying that out in ambulance stations would require a sufficient storage space with refrigeration and a safe and reliable delivery acceptance process. That's not something that's sort of standard in the ambulance sector at the moment, so it's something that would need to be developed. And Phil also mentioned paramedic engagement. So while we did train 74 paramedics, a sample of the testing data right at the end of the pilot showed us that our retention was quite low. Only 16% of the trained paramedics were actively testing at the end of the pilot. We talked to paramedics about this and identified some barriers to participation, which included the additional burden to working processes, so needing to collect additional equipment at the start of the shift, experiences of teething problems, such as working with fridge or getting sample issues, where people would try out a few tests, come up against those barriers, and stop testing because of that extra burden. And finally, the lack of the immediate usability to results. Because pathways weren't being changed during the pilot, some paramedics felt like they were taking on an additional burden without being able to use the results that they got. So I'll talk some more about the qualitative element of this evaluation. We got some feedback from patient representatives. So to do this, we commissioned an organisation called Mindfield Research to carry out some research into patient perspectives on troponin testing. Mindfield interviewed 15 residents in Greater Manchester. So these weren't people who were part of the pilot, that weren't being troponin tested, but they had prior experiences that made them a relevant perspective on this. So 10 of them had called 999 with chest pain in the past, and 5 were at high risk due to comorbidities. What we found from this is that patients felt that the additional clinical evidence in the form of troponin testing was beneficial, and it would increase their trust in paramedics' recommendations. But they wanted reassurance in the test's accuracy and what their next steps would be. They were particularly concerned about the potential pathway change of remaining at home if low risk. That was due to sort of a fear of being forgotten about by the healthcare system and not knowing what to do next. So they wanted a robust system that would safety net them if that was their outcome. We also talked to 8 of the participating paramedics, some of whom are here today. And overall, the response was really positive from paramedics. All of the participants felt that troponin testing had the potential to fit into pre-hospital roles and improve patient care, and sort of felt that they were doing better at their jobs because of it. Participants said that in most cases, the results affirmed their existing thoughts about the patient's condition and gave them more confidence in their recommendations. But it was particularly useful when they were dealing with more ambiguous presentations and provided reassurance to support a lower acuity pathway, like choosing SDEC rather than the ED. Paramedics felt that patients were really receptive to pre-hospital troponin testing, and they found that the results were really useful when communicating recommendations to patients. There were a few cases where patients were perhaps not keen to go to hospital before, but based on a moderate or high Tmax, they were actually more receptive to conveyance. And paramedics also reported positive experiences with hospital handovers, particularly when communicating with SDEC. So having the troponin result was a really useful bit of evidence when they were recommending going to SDEC. The paramedics saw really strong potential benefits to all the proposed pathway changes. And for those changes to be successful, they thought a few things were really essential. So that included a robust referral or follow-up mechanism for patients who are being discharged at the scene, effective training that would empower clinicians to make decisions, cross-system agreement, including hospitals and GPs, so really good communication across that healthcare system, and a shift in mindset around chest pain. So historically, the mindset would be, if someone has chest pain, they go straight to hospital, and questioning or changing that perspective will require a lot of systemic and organizational culture work. So the conclusions and recommendations from these findings. In terms of feasibility, the pilot implementation of pre-hospital troponin testing was successful and evidenced the feasibility of troponin testing in that pre-hospital setting. Troponin testing has the potential to improve cardiac pathways and reduce unnecessary conveyance, so it has really strong potential benefits. Looking towards the future, the scope of this pilot didn't include clinical impact and it didn't include clinical safety of potential pathway changes. So further evidence is needed to understand those pathway changes before they can be implemented at scale, which is something that Rick is going to talk about this afternoon. And our recommendations, in the short term, ambulance services should engage in research planning around the future of pre-hospital troponin testing, with the aim of making decisions around wider rollout when that clinical evidence is available. In the future, if troponin testing is found to be clinically beneficial and safe based on research, our evaluation report sets out potential steps to support a successful rollout, including recommendations for operational model selection, which is what Phil mentioned earlier about whether this is best suited for ambulances or for diagnostic cars. Selecting and piloting equipment, because there are a few different analyzers which have different features. Establishing a quality control process and change management within the ambulance service and the wider healthcare system, so that when if this change happens, it can be successful and sustainable. Thank you very much.